Good evening. I'm Dr. Wallace Tomlinson, and I'm the faculty advisor for the Tulane History of Medicine Society. And tonight it is my pleasure to interview and spend some time with and visit with Dr. Robert Heath. This is for the purposes of the filming for the archives of the American Neurosurgical Association. Dr. Heath has had and continues to have a very long and distinguished career in neurology and in psychiatry and in the area of exploring brain and behavior. He served as professor and as chairman of the department, a combined department of psychiatry and neurology at the Tulane University School of Medicine from 1949 until his retirement in 1980. As I say, he has established a reputation as a researcher, as a clinician, and as an outstanding medical educator. Dr. Heath is a native of Pittsburgh, Pennsylvania, where he grew up, and he received his undergraduate education, his baccalaureate degree from the University of Pittsburgh, and also his medical education, his MD degree from the University of Pittsburgh. Later, he received a doctorate in medical science from Columbia P&S. That was in 1949. In terms of his training, he interned at Mercy Hospital in Pittsburgh and then did a residency in neurology at the Neurological Institute. His fellowship in psychiatry was at the Pennsylvania Hospital in Philadelphia. The list of his honors, the list of his consultative posts is very long and very distinguished. I would note that he is the author of 425 papers and that he is also the author of 3 books. So it is a real pleasure, Dr. Heath, to have you with us tonight and to spend this time with you. I will be addressing primarily your work in and contributions to the area of brain and behavior and the signal research and contributions that you have involved yourself in through the course of your professional life. You came back from the Second War and joined Fred Mettler's lab in New York at Columbia. I believe you and Dr. Larry Poole worked together. How did you get interested in that field, and can you sort of tell us what sort of research you were doing there?
Well, I completed my residency in neurology before the war, and part of my most of my training in psychiatry, and did psychiatry during the service, and was very interested in going on with research in neurosciences with the aim of correlating brain activity with behavior, trying to relate the two things. I guess getting into the broad mind-brain problem. And had a Tilney Fellowship working with Fred Mettler in the lab. And at that time, there was a lot of psychosurgery going on, operations on the frontal lobes for severely, intractably ill psychiatric patients. Mettler had done a great deal of research work on the frontal lobes in monkeys, exploring the connections and also observing behavior with ablation of parts of the various areas of the prefrontal lobes. And that was, I suppose, the primary impetus for Larry Poole and I getting into the psychosurgery business, if you want to call it such. We were aware that there were sometimes detrimental effects from the conventional lobotomies being done at that time, which undercut the radiation supposedly from the thalamus to the frontal cortex. They were very extensive, undercut a wide area of the frontal lobes. And based on some of Mettler's experiences with monkeys, we wondered if we couldn't come up with a more conservative approach by taking off specific areas of the prefrontal cortex. The aim was to try to get the beneficial effects without the deleterious effects, trying to separate the two. And the operation that we devised for removing selected parts of the frontal cortex was called tupectomy. And Larry and I did a couple of them, removing principally areas 9 and 10, because in Mettler's experience, this appeared to be the best areas to remove to get the beneficial effects without detrimental effects. The patients did fairly well, and that formed the basis then of the Columbia Greystone project, which was set up under Mettler's direction. Larry headed neurosurgery, and I headed psychiatry and neurology. Landis and Joe Zubin headed the psychology, and we had a great many people then in all of these divisions who studied the patients. We set up at the Greystone Hospital, and we had 24 patients who were operated upon with removals of specific areas of the frontal cortex. In each instance it was bilateral, and there were specific Brodmann's areas or combinations of Brodmann's areas removed in each of the patients, and the other 24 patients that were worked up served as controls. They weren't actually operated on, but they were taken to the operating room and came back with a bandage on their head and their head shaved, so that it was a fairly well-controlled study and an attempt to try to demarcate the parts of the frontal lobe which, when removed, might give the best beneficial effects, and also was an attempt to find out where the deleterious effects were coming from. Okay. So that's how we got into it, and that was the extent of the topectomy experience.
Did you have much contact with Dr. Walter Freeman in those years?
Yes, well, not a lot, but had some contact, and it was always interesting and rewarding. Walter, of course, did the first lobotomies in this country, and I guess he did his first cases with Watts in 1936, in the fall, shortly after Egas Moniz came out with his monograph describing his first 20 patients. I think that he came out with that in June of 36, and then Freeman and Watts did their first patient in September of 46. We used to see Walter up in the labs occasionally. He had some complications from some of those operations, which were done fairly blindly with the trephine hole and leucotome, doing the severing of the fibers. And he would bring the brains up for Fred Mettler to examine, because of Fred's extensive experience with monkeys and their connections. And I think they actually did a publication or two together. So we had contact with Walter, and it was always very interesting.
Okay, how...
We did, I had more extensive contact when we did our Columbia Greystone report at the Academy of Medicine in New York. Walter was a discussant of my section, and that was, I think, the first time that he announced his ice pick operation, where he would essentially take an ice pick and break through the orbit with a hammer and swing it back and forth and sever the frontal cortical connections. And he described that in detail at that time. Of course, he went on to do a great many of those.
Okay. How did you become interested in subcortical work? How did you move from the cortex to the subcortex? And can you kind of tell us a little bit about how that brought you to Tulane and to New Orleans?
Right. Well, when I was in the lab with Fred, I got very interested in looking at subcortical structures and their effects on behavior. And the reason for that was because when we did the frontal lobe operations, they were relatively ineffective in touching the basic symptom complex of the schizophrenic patients. In time, Moniz did his first patients on through Freeman's, and this was our experience in the Columbia Greystone project. We got our best results in patients who had an affective disorder, who were depressed, or who had very inappropriate emotion of a neurotic type, like the obsessive compulsive neurotic has. But we weren't able to touch the basic disrupted emotional symptoms of the schizophrenic, where they couldn't experience pleasure, where they were markedly reduced in their level of awareness towards the dreamy state, with their delusions, and where they had profound sensory disturbances in the form of hallucinations and disturbances in body image, other and sometimes somatosensory disturbances of various sorts. They were that basic system, that basic interruption in their emotional functioning was not touched by the cortical operations. And while in the lab, actually Fred had done some work with caudate ablations and reported that those animals were essentially dazed, out of contact, had some catatonic features. They had many symptoms which objectively looked like the symptoms you see in the schizophrenics, particularly in the catatonics. They were reduced, out of contact, non-responsive. Their emotional system mechanism was grossly disrupted. I began making lesions in subcortical structures first off, and found that it did disrupt the emotional system, much as it was disrupted in schizophrenics. But as time went on and we explored that more extensively, we began to realize it wasn't the disruption of the caudate that did that, but it was more related to lesions in the basal forebrain, which we later named the septal region, that part of the basal forebrain extending from the anterior commissure rostrally at the base of the ventricle, rostrally to the tip of the ventricle, and just a little bit lateral to the midline, including the accumbens where it's joined with the base of the caudate. That was the important area, and of course that's become very much the focus now in Alzheimer's too. Those are the cholinergic cells. And the reason for coming to Tulane was I got the impression that since ablation produced that gross disruption, that it must somehow, in the schizophrenics who don't have any structural lesion, it must somehow be functioning abnormally to produce an effect resembling what we saw when we destroyed it. And I wanted to put in electrodes and stimulate it in some patients. We did that in animals, in monkeys and cats, and it would produce an alerting, and the animals seemed to enjoy it. Mm-hmm. It was pleasurable. We couldn't get on with that at Columbia because people wanted to go on with the frontal lobe work. So I was offered the job at Tulane, and we had Charity Hospital and thousands of patients who were chronically hospitalized, not responding to treatment, and provided an opportunity. So I came here, and within a year, and by 1950, we were able to work out techniques so we could put those electrodes in place and attempt to stimulate them.
Okay. You began, I believe, in the spring of 1950. Can you tell us a little bit about the first couple of patients that you did deep electrode implantation on?
On the basis of our animal studies, even though we were using stereotactic techniques, we were never certain whether it was the septal region per se, the base of the caudate, or the anterior thalamus that was producing the desirable effects of alerting the animal, seemingly bring them into better contact with reality. We didn't know which of those structures was principally involved. The first patient we did, we put our electrodes into the anterior thalamus and stimulated that, and nothing happened. And so by the time we got to doing the second one, which was later in 1950, we realized it was the basal forebrain or septal region that was involved, and we put our electrodes into the septal region, and we had a very satisfactory response.
In what way was the response?
We had
as you recall it.
Yeah, we had an intractably ill schizophrenic patient who had been through all of the then available treatments, which included insulin shock and electroshock, and the various supportive therapies, without any benefit at all. And so this seemed like a good candidate, and the alternative was a lifelong existence in the state hospital. So we stimulated her. In that time, we did an open operation on these first few. We would open in the ventricle, much like Madrosa is doing now with the putting in his adrenal implants into the head of the caudate. We opened in much that same way and held the electrode down into the septal region, which was easily identifiable because you could see the foramen of Monroe, and we moved about 10 millimeters in front of the foramen of Monroe, and that would put us right into smack into the region of the accumbens septi nucleus. And this patient brightened up and did very well. She held the gains for a fairly prolonged period, about 5 years before she ultimately relapsed. But that was enough encouragement to go on and do others. And so we did a series of them, and in the course of about a year, we began to evolve our closed method, our stereotactic procedure for implanting these electrodes so we could leave them in place.
Okay. But you say we. Who was we?
Right. Well, we had this group who came down from Columbia or Pennsylvania. Bob Hodes was the neurophysiologist who came down with me. Bob was from the Johnson Foundation. Frank Garcia was the neurosurgeon who came down from the Neurological Institute, and we had some of the psychologists who were on the Columbia Greystone Project, specifically Gene King and Kathy Young. And that was the nucleus of our group. Of course, we had some supportive people in psychiatry and neurology as well. But Hodes and Garcia and I first evolved a stereotactic procedure using the old frame that Bailey had at first. And with that, we were able to implant the electrodes through a tree-fine hole, and we crudely fixed them at the bone so they stayed in position, but they would only stay in position in these early days, for a matter of a few days or a week. We had to evolve methods for keeping them in longer, because if we stimulated these patients, they would get a temporary beneficial effect. These are old, out-of-contact patients with delusions and hallucinations, and when we stimulated them, they would brighten up. If they were catatonic and mute, they would begin to talk. If they were very delusional, they would tend to come back towards reality to varying degrees.
Mm-hmm.
But they didn't hold it. Sometimes it would last for only a day or two, and sometimes a few weeks. And this was a disappointing aspect of working with the schizophrenics, and it was an experience that many people had previously as well.
So you would repeatedly stimulate these areas. Were you attempting to kindle, or?
That was that became then the approach that we used. If we could keep these electrodes in and leave them in for a longer period of time and repeatedly stimulate them, that we might change the dysrhythmia. Now, this brings in a separate issue, which is a very important one, and that is that with these electrodes in place, we could not only treat them through electrical stimulation, but we could make recordings. And when we made our recordings, we consistently came up with an abnormality on the EEG recording from these deep structures in the form of a spike and slow wave. This correlated with their gross psychotic behavior, seemingly. Now, very early in the game, we realized we had to place electrodes at other sites in the septal region to make sure that this wasn't just an artifact of implantation that we were recording. Mm-hmm. It proved to be very focal, and to jump way ahead over the years, that has been the case. It was a focal abnormality. We first reported that spike and slow wave activity at our meeting here in 1952, which we called after we did 26 patients.
Can you tell us about that meeting?
Yeah, I'll lead into that.
Okay.
But the chronology was that in the first patients, we just had in 1 or 2 electrodes. Well, the first patient, only 1 electrode. Then we put about 3 in through this hole, through the open procedure for a very short period of time, which gave us some comparison between what we were getting from the septal region versus what happened if we stimulated and recorded from the caudate, and versus what happened if we stimulated and recorded from the thalamus. Well, realizing we had to have these in place longer to get this so-called, we didn't call it a kindling effect, but that was the concept, that if we repeatedly stimulated, we could permanently change the dysrhythmia and keep these patients well longer. We had to develop better techniques for anchoring those electrodes at the bone so they would stay accurately in position for more and more prolonged periods, and we got it. By the time we had this meeting in 1952, we were able to leave them in for several months, and then later we got so we could leave them in for a year and a half, and repeatedly record and stimulate. And this, with the schizophrenics, we still, even with repeated stimulations over months at a time, we're not able to keep the patients from falling back and becoming symptomatic again. Now, we did get better results in other types of patients, which we then began to move into.
Okay.
Now, your question
about the meeting, you had 26 patients and you made a national presentation.
That's right, and we invited in a number of representatives from all of the appropriate neuroscience specialties and presented this. It was published in a book called Studies in Schizophrenia, which was Harvard Press. But at that meeting, this, of course, what shall I say, it caused a great deal of emotional upset to a lot of people who attended that meeting. It was very upsetting because there was a concern about brain-mind control came up, and it created a tremendous amount of controversy. By that time, we realized that when we stimulated in the basal forebrain receptor region, we could get a pleasure response. And if a patient was very depressed, you could immediately turn that depressed mood into one of ecstasy almost, great happiness at least. They began to feel very good. Contrary-wise, by the early 1952, 1953, we could turn on aversive emotions of an intense degree too by stimulating other sites. We found sites which, when stimulated, would turn on rage or intense fear or to an inordinate degree. So these sort of responses created a great deal of concern in the scientific community. Okay. It became controversial almost immediately.
Well, now, you described the pleasure that the patients experience, these anhedonic schizophrenic patients, so that in a sense this was kind of a pleasure area of the brain. And you were reporting this in 52.
Yes, this was the first report. We had those 26 patients, and we reported this response to stimulation, which was an alerting response and a feeling of pleasure that it induced.
Okay, well, Olds didn't report until about 55, if I'm not mistaken.
That's right. No, in 54, he came in with 12 rats, but in 52, we had the 26 humans that we'd had the electrodes in and stimulated this area, the septal region, and then, but Olds' report of his first 12 rats in 1954 gained much more credence, seemingly because it didn't stir the controversy. He was dealing with rats. Of course, you wouldn't have known that these self-stimulating rats were doing it for pleasure if we hadn't had a subjective report of pleasure from our patients. It wouldn't have amounted to much. In fact, the rats would self-stimulate in the septal region. That was accepted more than our report of the patients because it didn't have the controversial aspects to it.
Yeah. Well, as the 50s progressed, you worked in the area of you continued your basic research, worked in the area of intractable pain, also developed techniques for placing cannula in to inject neurotransmitters. Can you kind of tell us a little bit about that aspect of your research as time went on?
There were several trends evolved. Of course, the original reason for our putting in the electrodes because we thought not only would it be a more effective treatment, particularly for schizophrenia, than the extensive frontal lobe operations, but it was much less damaging. It was a more conservative procedure, actually, despite the fact that it stirred all that controversy, which I think is illogical. It's emotional rather than reasonable. But some of the trends that evolved were very interesting. We got very discouraged after a couple of years. Our schizophrenic patients really were not responding to this electrical stimulation. But we had the pleasure system, and we also knew that when we stimulated this basal forebrain region, we were paralleling these human studies with extensive animal studies. But we found that we could activate the whole pituitary adrenal stress mechanism. And of course, they were treating a lot of other diseases by giving adrenal hormones. Cancer of the breast, for example. Several cancers were being treated with steroid therapies, and so was rheumatoid arthritis. So we had some patients who were intractably ill with cancer, rheumatoid arthritis, who also had intractable pain. And we decided to stimulate them for two reasons. One, to see what turning on pleasure would do to their feelings of intense pain. And secondly, to find out what release of this, activation of this, or release of the steroids, adrenal, steroids is all we knew at that time. We were measuring 1,700 for steroids, but we knew that it was activating that system, and we wanted to see what that would do to inflammation of rheumatoid arthritis and what it might do to the cancerous lesions. And those were the first patients who were treated with stimulation of the brain for intractable pain. They were patients who hadn't responded to medications for their pain, and they got prompt relief from their intractable pain. And of course, this treatment still goes on in several centers. Don Richardson here is doing quite a bit with pain through central stimulation. And those were through stimulation of the pleasure centers. So that was one trend that evolved. And then you mentioned another factor, and that
neurotransmitters. So you had a patient, I believe, about 1961 with Parkinson's disease.
Yeah, well, we had to, right. See, always when we were doing the schizophrenics and these other patients, these ones with other diseases, we had a therapeutic rationale for putting electrodes in, served as controls on what we were getting on our psychotic schizophrenic patients, too. We were go back to the recordings. I said we had that spike and slow wave which correlated with psychotic behavior. It was focal in the recordings from the septal region. And these patients with the other diseases didn't have that abnormality in their septal recordings. So there were a control on that effect. And I can go on and I think I'll develop the importance of that recording finding a little bit before I go on with the your question about the cannulas.
Sure.
Because I'm always pondering this question of why didn't the schizophrenics respond? They were different. Actually, they were different when you stimulated them. They didn't get as much of a pleasure response as these patients with other disorders did. In addition to the pain cases, we had some patients with Parkinsonism that I'll come back to. And we had a number of epileptic patients. We used epileptic patients who couldn't be controlled with medication. I say we used them, we treated them in this way. And they served as a control on the recordings, and we were able to find out what was happening through these subcortical structures during the time that seizure was being generated as well. So we got a lot of information on these other disease processes too. But from the standpoint of schizophrenia, we began to realize very early that since there was no structural abnormality and we had this recording abnormality focal at this site, that we postulated that there must be some sort of a chemical defect that was affecting the transmission probably at the synapse. And we began looking at chemical transmitters. And that's how we ultimately ended up by isolating a protein fraction from the serum. We thought it was an abnormal enzyme for breaking down of catechols, that it was acting on the substrate in an abnormal way to produce an end product that caused the misfiring. That hasn't proved to be the case. Ultimately, we've gone on and found out that it is antibody, but this focal recording was very important because the substance in the serum, which proved to be immunoglobulin G, appears to be an antibody that's attacking a unique antigen on the receptor that's present only at that focal site in the brain. That is our newest development, and it's been very helpful in revealing the pathogenesis of schizophrenia. And one of the big advantages of having this finding in humans was that we were able to develop an animal model. We put these electrodes into the monkeys in the same spots, and that monkey proved to be an excellent assay for working out the biochemical basis of schizophrenia, what was going on to produce this abnormal activity at this site without producing a structural lesion.
Okay, you're now addressing how you moved from your stimulation studies into the area of studying the chemical aspects
Correct.
of schizophrenia. You're making this move now. Can you tell us how you struck on the idea initially that this was some sort of an immune phenomenon? I mean, was there a process you went through as you moved in that direction?
Right, and you'd mentioned the use of the cannulas.
Yes, I had mentioned the use of the cannulas.
And this comes in at this juncture because we assumed that, as I said, that there must be a biochemical abnormality to produce this change, and we weren't getting results in schizophrenics. So we wondered if we use chemical stimulation instead of electrical stimulation, that we could get better results. So we did develop a cannula later in the 1950s, which we were able to implant and leave in place for prolonged periods, just as we were able to leave our electrodes in, with which we could administer exact volumes of a specific chemical transmitter. We had the ability to then wash it out if we wanted to use another chemical and put that in with volumetric accuracy, and we could put it with precision into specific regions of the brain. We began using that, and that did give us more long-lasting results with our schizophrenics, and we had some results on through the late 50s and early 60s, which were much more gratifying than the earlier results with just electrical stimulation. But we also then used that cannula in the treatment of epileptics. As I indicated earlier, we were able, with the deep electrodes in place, to find out what was going on at the deep structures in association with the development of a seizure, and what was going on interictally, because we could record constantly over prolonged periods of time. But we found that if we put the chemicals directly into the basal forebrain, and particularly acetylcholine, that we could fire those cells and produce a sort of a focal discharge in the septal region, which had the ability to inhibit discharges in the hippocampus with which it was connected. And that, of course, the seizures had built up in the hippocampus. That seemed to be where they started primarily, in the hippocampus and parts of the amygdala. The firing off the septal region with the acetylcholine inhibited the cells in the hippocampus and had a beneficial effect on controlling seizures. But we also used it in the Parkinson patients. And particularly after Horny-Kiewicz gave his presented his first paper in 1960 showing a depletion of catechol in the striatum. We, prior to that, had used this cannula with the idea of putting alcohol lesions in the thalamus, to do the thalamotomy the way Irving Cooper was doing them, putting alcohol, making an alcohol lesion in the thalamus. But when that report came out showing there was a depletion of norepinephrine and dopamine in the striatum, we elected to also put these cannulae directly into the striatum and administer the dopamine and norepinephrine directly into the striatum. Now, we only were able to do one patient with that in 1960. But when we did, he got marked improvement in both his rigidity and his tremor, and we were able to follow him. We put it in on numerous occasions, 15 or 16 times into the head of the caudate nucleus. And his tremor was markedly reduced, actually stopped. His rigidity was much improved, and that benefit continued. That improvement continued for a 10-year period that we followed this man. He was rather elderly and died of an intercurrent disease after about 10 years. But we didn't do any more because L-DOPA came in until just recently. And now we've gone back and we've done a couple again with exactly the same procedure within the last 5 months. And we're also getting beneficial results with that. It's a much less destructive procedure than transferring the adrenal tissue into the striatum, and our results seem to be comparable to the best reports that are coming out with the use of the adrenal medullary transplant into the head of the caudate.
In the 60s, you moved on, your research expanded further, you moved into new areas having to do with cerebellar stimulation and cerebellar pacemaking. Can you develop that a bit?
This was, again, a derivative of the electrode implantation. Beginning way back in the early 1950s, were able to put these electrodes into numerous sites and leave them in for prolonged periods. And it gave us the advantage of being able to follow the physiology of the brain at these particular sites through our recordings while we were observing behavior and while we were able to talk to our patients and have them report to us their thoughts and feelings. It proved to be an excellent technique for making correlations between brain activity and activity of what was going on in the mind. And we began to make correlations, particularly between the emotional state of the patient and what was going on at these deep sites in the brain. Well, you mentioned already, and we discussed the fact that we had a pleasure system.
Right.
When we stimulated, we turned on pleasure. But from the recording standpoint, it was very interesting that when patients felt pleasure, then this region would fire. And of course, we put in the chemicals and stimulated it. They felt extreme pleasure at that, in association with that as well. We also found other sites which were correlated with aversive emotion, which if we stimulated, and one of them was the hippocampus, we would turn on negative feelings such as anger or fear. And we had a site in the tegmentum and the mesencephalon, which if stimulated would turn on intense killing rage instantaneously. But when we made recordings from those sites, we found that if the patient thoughts were of a negative sort, if we stirred up a lot of negative emotion, a lot of anger or fear when interviewing them, that the recordings would show these sites to be firing. So it was a way of making correlations between pleasurable and aversive emotions. And the principal pleasure sites were the septal region and the lateral amygdala. The principal aversive sites were the medial amygdala, hippocampus, and these sites in the tegmentum and part of the hypothalamus. But the big jump that led into the cerebellum was having an opportunity to work with some of Harlow's sensory deprived monkeys. These monkeys, if sensory deprived for the first 3 to 6 months in their lives, would develop many of the symptoms as best a monkey could, the objective symptoms that the schizophrenics had, that they would sit in a corner isolated, rock back and forth. They were autistic. They had inappropriate emotionality. They could never enjoy pleasure, seemingly. For example, they couldn't get involved in sexual activities as they grew up. They permanently were affected with this deficit in their emotional system, their emotional responsiveness. We had an opportunity to put electrodes into some of those monkeys, and we did find abnormal activity of the sort we found in the schizophrenics in the septal region, but we were also interested in looking at the sensory relay nuclei in those animals with our electrodes, because it was sensory deprivation that produced this emotional deprivation. So we implanted the deep cerebellar nuclei, and we implanted those because Harlow and Mason, who worked with him, had found that deprivation of vestibular proprioceptive input, somatosensory input, was the most important factor in creating that abnormal syndrome. So we looked at that, and we looked at the thalamic nuclei with electrodes, and we found that when there was spiking in the septal region and in the hippocampus when they were showing rage, there was also spiking at the same time often in the cerebellum. And that led us to do anatomical techniques to see if the sensory relay nuclei were interconnected with the sites where we had made the correlation with the emotional states, both pleasurable and aversive. And we worked out a much more extensive emotional network in the brain, much more extensive than the limbic system, because the septal region was further forward. It's included the cerebellum and other sensory relay nuclei, in addition to the more conventional so-called limbic system, which was supposed to be the part of the brain that correlated, where activity correlated with emotion. And we were able to do this because we had the advantage of having patients with electrodes in who could tell us their thoughts and feelings, because the emotions are subjective as well as having an objective component. And by having the electrodes in, we were able to make the correlation between those subjective and objective behavioral observations and the brain activity. And we published on this more extensive emotional system. But this has been one of the big advantages of this psychosurgical procedure of implanting electrodes in such a way that leave them in place for prolonged periods. Gave us the opportunity to correlate what was going on with what was going on in the brain, and led, supported by these animal studies, to the demonstration of a very extensive emotional network, which involved the sites where, the forebrain sites where we had correlated pleasure and pain with emotion, but we found that it was very much tied in with the sensory system, and clinically this is so. You don't have an emotion without having an alteration in your sensory perception.
Mm-hmm.
You know, you listen to the television show, they turn on the mood music to set your mood for the play that you're going to look at. And of course, when you have a particularly emotional state, you think of certain sensory cues as well. When you're sad, there's the funeral march. When you're happy, it's the Tales of the Underwoods. And you can go on and cite one after another of these.
Interrelationships.
Vestibular proprioceptive relationship is very interesting. Kids like to be tossed in the air, the merry-go-round and roller coaster, and you go along with vestibular proprioceptive stimulation that can be very pleasurable, or it can be the other aversives too.
Let me ask you kind of a global question, and it's going to sort of, in a way, call on you to be a little bit repetitive, but I think hopefully kind of sum up this issue. And that is, over the course of the past 43 years, what do you see as being your major contributions to our understanding of the pathways of emotion, the basis of emotion, the behavioral aspects of brain function and disturbed brain function? I mean, can you, looking back on it, so some things really stand out here? And this is what you've been talking about. I'm just...
Yeah, well, I think the major thing was the evolution of the technique, which made it possible to simultaneously monitor behavior, both introspectively and objectively, while looking at the physiological activity going on in the brain. I think that correlation has been an important factor, and I think it's formed the basis for going ahead with additional treatments. You had mentioned the cerebellar stimulation. As I said, all along we've been looking for better ways of physiologically treating the intractable behavioral disorders, and when we found that the cerebellum was tied into these sites where we'd made correlations with altered pathological behavior, we began to look at its function, the way the cerebellum affected these rostral forebrain sites where those correlations had been made. One of the critical findings that led to cerebellar stimulation in our hands was the fact that in the animals, stimulation of the midline cerebellum, whether it be on the cortex or the deep nuclei, inhibited unit activity in the hippocampus, which now the unit activity in the hippocampus was where we would get the abnormal activity in association with inappropriate rage, the outbursts of rage in the epileptic, and it was where seizures started. So we reasoned that if we could suppress that aversive system, it could have a therapeutic benefit on epileptics and certain types of behavioral disorders. It also tended to activate the pleasure system when the midline cerebellum was stimulated. And so that was our rationale for going ahead with some patients. And because we had recorded this intense abnormal activity in association with violent behavior localized in the hippocampus, we first selected for cerebellar stimulation patients who displayed violent behavior and got rather good results. We first implanted those indwelling or those permanent cerebellar stimulators in 1976, and that first patient is still controlled. We got him out of the state hospital, and he's been living at home ever since. He's without his uncontrollable outbursts of rage. And we've had our best results with the patients who had the episodic uncontrollable rage behavioral pathology. We didn't do very well with the schizophrenics. So that's a biochemical abnormality, and those cells are affected by the biochemical process apparently, and physiological means have not been, nothing that we've come up with has been very effective in helping the schizophrenics.
Okay. What do you see as, and again you kind of touched on this, I'm going back over it, as the major therapeutic benefits that have accrued to your many years of work in this area?
Well, I'm still hoping that the major therapeutic benefits are yet to come, when we can further develop the biochemical approaches to schizophrenia. But aside from that issue, I think our best therapeutic benefits with the psychosurgical physiological procedures have been with patients with violent, rageful behavior. We've been, I think, quite helpful in certain types of epileptics through our cannula treatment, the introduction of chemicals. It looks like we've evolved something that is probably going to be fairly effective in the treatment of Parkinsonian patients that no longer respond to L-DOPA or are sensitive and can't take the L-DOPA. But I think probably the greatest benefits are yet to come on the basis of our having been able to establish some correlations between activity of the mind and activity of the brain, particularly through correlating emotion, showing this extensive neural network, showing that emotion and sensory perception are really part of one process, and we've also begun to tie in the memory phenomena using what tools are available to correlate with memory, which would be the demonstration that the acetylcholine mechanism is involved. When we make lesions, we found essentially that these sites that are so critical in emotion and in sensory perception are also the sites that can affect the choline-acetyltransferase levels in the cortex.
And again,
if you look clinically, you find that memory is an integral part of the sensory system and the emotional system as well.
Absolutely.
You don't have an emotion without it stirring a memory, and memories are the reason for emotions being stirred in most instances, except for those rare instances where we're having an emotional response because of some immediate feed-in.
Okay.
So that the memory, sensory perception, and emotion all are proving to be part of the same system in the brain. We think of them as different phenomena as clinicians and as laymen, but it looks like neurologically, and if you think as a behavioral scientist, that they're really the same process in essence.
Okay, of course, this has been one of the great mysteries that philosophers have addressed for many centuries, the relationship between the brain and the mind. And you've devoted, in a way, your professional life to the study of this area, and as I say, made signal contributions in helping us to understand better these interrelations between perception, between memory, and also between emotionality. And coming back to what happened in '52 when you presented those 26 cases, certainly it's a matter of the historical record that your research has been something that has stirred up a lot of controversy through time. And I think it's fair to say that you yourself have been occasionally the object of calumny, of vituperative criticism, some of it very irrational. Do you have a feel for why? I mean, why it stirred up for such a long time? I mean, not just the work you did in '52, but it continued.
Well, I think you have to think of the state of the field of psychiatry in particular over that period of time. We had a strong psychoanalytic orientation, particularly through those early years, and the general thinking in the field of psychiatry was that all behavioral pathology was essentially due to environmental happenings. There was very little interest or focus on the brain, and to come up with some evidence that there was a biological basis for behavior was sort of heresy during that period. There were these exaggerated concerns about what could be done by physical manipulation of the brain.
Mind control sort of thing.
The mind control issue was a highly emotional one. That we would make zombies out of people and put them under our control and so on, and none of which can happen.
No, it's not. Yeah, right.
But it stirred emotions in our profession, to say the least.
Okay. Well, what sort of advice would you give to someone who is now early in their career moving into the area of the neurosciences and the study of the neurological basis of behavior, both normal and disordered? I mean, how do you see the future for people moving into this area? And I know one of your bits of advice, I imagine, will be stick to your guns no matter what the criticism is if you really believe that you're right. But could you kind of develop that a bit?
Yeah. Well, I think it's a very exciting field. The area of the mind is so important, and I think now everyone would concede that there have been definite advances made to demonstrate the physical basis for mind. At least some aspects of it. There's never going to be a one-to-one relationship, but I think there's enough evidence available now to indicate that we can alter behavior by methods which affect the brain and affect brain activity. And if we learn more about the brain and particularly to find out how focal within the brain many of these functions dealing with behavior are, that it opens a very exciting frontier. Use of biological techniques, but oriented towards treatment of mental disorders, I think is just a fascinating, wide open field, a real challenge. We have more people ill with just one mental disease, schizophrenia, than with any other major disease, and probably nearly as many as there are with 80% of the other major diseases. If you just consider the number that are disabled, it's a real challenge and a real opportunity to, I think, to contribute to the benefit of mankind as a whole.
You've mentioned that through the years that the patients with schizophrenia did tend to be more resistant to stimulation and other therapeutic modalities, experimental and otherwise, by which you intervene. What do you see in the future? You say you hope the best is to come yet, the most important things are to come. What do you see coming? Can you say what you see coming down the pike?
Well, I think, first of all, that we're going to be able to develop a specific treatment for schizophrenia. You know, we've come a long way with the neuroleptic medications, but they're still not that specific and have undesirable side effects that are a considerable degree. But the very big issue is the problem of emotion. If we could find some way of controlling emotion, it would benefit mankind tremendously. I mean, throughout the ages as man has evolved, and particularly as we've developed our cortical mantle, especially over the last 30 to 40,000 years, since the days of the Neanderthal, the basic emotional system has remained the same. We've developed new, vast, and tremendous technological advances. Many of those advances are potentially extremely destructive, up to and including the atomic bomb. hydrogen bomb. Yet our basic emotional system hasn't changed at all. We're still behaving
In the last
in our
100,000 years.
interpersonal
Yeah.
relationships very much like cavemen did, only instead of having clubs to hurl at the next guy and rocks to hurl, we have atomic bombs to hurl, which can wipe out all of mankind. I think there has to, if we don't make some progress in being able to understand the mind and how to control our emotions and keep things under control a little bit better, we're going to, our future is really not very secure.
Very good. Dr. Heath, it has really been a pleasure to have spent this last hour with you discussing your professional career from the 1940s forward. And I hope you have many more years to continue your research and your investigation into an area which, of course, is of vital interest not only to neurologists, psychiatrists, neurosurgeons, but I think to, as you say, to the human race as a whole, for the sake of our future. Thank you.